Hey everyone, hopefully you can hear me okay. Hopefully the Zoom link is working. I just want to welcome everybody to this very special joint grand rounds with the Departments of Neurosurgery and Anesthesiology. I have the honor this morning of introducing today's speaker, Dr. Lingzhong Meng. Dr. Meng is a professor of anesthesiology and vice chair for clinical and outcomes research in the Department of Anesthesiology at the Indiana University School of Medicine. He obtained his medical degree from Peking Union Medical College in Beijing, China, and completed his residency in anesthesiology at UCLA. Dr. Meng, I'll take just a minute, tell you a little bit about him. He's enjoyed a prolific career. He's had a tremendous impact on the anesthesia and neuroscience literature. He's worked at several renowned institutions throughout the United States, including UCLA, UCSF, Duke, and Yale, where he was the chief of neuroanesthesia, and where I was fortunate to work alongside him for several years. Dr. Meng's research interests include perioperative neurosciences, cerebral blood flow regulation, cerebral monitoring, hemodynamic monitoring, database and outcomes research, and machine learning. Dr. Meng is actively engaged in several clinical trials, has numerous collaborations, both in medicine and industry around the world. His contributions have earned him more than 200 invited talks, more than 120 peer-reviewed articles, and an H-index of 32. He's had an especially big impact in the COVID literature during the recent pandemic, and his June 2020 article that was published in Anesthesiology on Wuhan's experience with intubation and ventilation during the COVID pandemic was the most cited paper in anesthesiology in 2020 or 2021, a really big accomplishment. On a personal note, in addition to being a very close friend of mine, I'm truly honored and humbled to consider Dr. Meng a mentor and a colleague. During the time that he and I worked side by side together at Yale, I learned a tremendous amount from him, both in clinical anesthesia and in research. Dr. Meng has tremendous energy and charisma. He's an innovative thinker and scientist, and to be in his presence is truly to be in the presence of one of the greatest giants in our field in modern anesthesia and perioperative neurosciences. I'm so thrilled that he's able to join us today, even if it's only virtually. Hopefully at some point we'll have him come down and he can spend a little more time with us. We can show him our beautiful campus. But I'm at least thrilled to be able to have the opportunity to introduce him here to all of you today at Mayo Clinic this morning. And then before I turn the mic over to Dr. Meng, I just want to take just a really brief moment and thank Dr. Q and Dr. Abel and the Grand Rounds committees for both departments. I know there's a lot of work that went into helping to coordinate the special joint Grand Rounds. I really do appreciate it. Without further ado, I'm going to turn things over to Dr. Meng.
Good morning. Thank you so much, Sean. I'm very impressed and touched by your introduction. I appreciate that. And then special thanks to Dr. Q, Dr. Abel. I also want to greet to Ben and then everybody from the departments of neurosurgery and anesthesia. So it's early in the morning. Happy July 4th in advance. So I'm going to jump on my slides right away. So I'm going to share my screen. So here, share. I assume you hear me okay, right?
Yes.
Yeah, I'm going to first day, July, this is July 3rd. I'm going to work with first day with a new C1. So I told them I have to give the grand rounds. I must. So, okay, anyhow. And then this is the topic. I really have nothing to be worried on this. Objective is to use the historic and the real world data to facilitate the appreciation of CBF, which is cerebral blood flow regulation, especially cerebral autoregulation. So I'm not going to talk about the fancy machine learning, AI, robots I just saw on the ads, and then, among all the most advanced, technologies. So I'm going to talk about actually history. So first of all, let's take a look briefly of this work. This work was published 2019. The topic is about targeting MAP. This is cardiac, this is not a neuro, by monitoring cerebral autoregulation. And then the outcome, the try to affect is post-operative delirium. It's better post-operative, use the standardized term. Otherwise, I cannot even, some people cannot get this when you do literature search among older patients. So the intervention is, the target is MAP. So the goal is based on the guidance of cerebral autoregulation to manage MAP to see if there's effects on POD. So they try to maintain MAP above the lower limit of autoregulation they identified through the monitoring. So here are the results. The results is there's almost 53 POD in standard care, and then 38 the incidence in the targeted MAP management group. There's a difference. That's exciting. Yeah, what's more exciting is just a small size patients randomized, and then you get exciting results. But of course, the power is not as robust as I mean the p-value and then the 95 CI. So it's a little bit wider, 0.97, almost 0.03 to 1. That's not rigorous, robust. Okay, so over here, I want to pause for a second. What is this? What is cerebral autoregulation? What is the lower limit? And then how do you do this? So I want to go back to 128 years. This is Sir Baylis, the 128 years. This paper was published in 1895. This is his conclusion. Cerebral circulation passively follows the changes in pressure, including arterial and venous pressure. Okay. It's a passive flow, passive, that's the key word. So in all physiological conditions, a rise of ABP accelerate the flow through the brain, and a fall slackens it. So that's the conclusion. So let's remember that, remember which year this was published, and then the conclusion, the keywords. So this is actually, I think, is a research group affiliated to the neurosurgical department at Duke. The work was done in 1960s. Dr. Greenfield. So basically, it's a group of neurosurgical patients. They received craniotomy for supratentorial malignancy resection. About 20 days following procedure, when the patient was doing really well, recovered, and in good condition, they went back to patients, and they dissect the anatomy over here in the neck, and they selectively injects. I did not read all the details, but at that time, this is targeted chemotherapy, right? And then target internal carotid artery. Okay, because of that, what they did is they did experiments. They use this is just a picture, not necessarily the same device they used at that time. What they call it is the electromagnetic flow meter. So they put this flow meter around the common carotid artery over here. And then they accrue the external artery so that whatever the flow over here goes internal, so they will know the blood flow to the brain. And then they accrue the internal over here, they measure over here, they will know the blood flow to the external. So that way you can differentiate two tissue bed. One is the brain perfused via internal carotid artery. The other one is extracranial face, neck, tissue bed, perfused by external carotid artery. So over here is a brief introduction of the the data recorded is of course it's arterial blood pressure and then the flow meter, and then this is a pulsatile flow. Of course, the flow is a pulsatile, and then this is a mean. Okay, over here. So this is the intravenous. Remember, it's intravenous non-epi injection. This is A is before injection, B is after injection. You can tell following about a 5 minute, following the non-epi injection, you see the blood pressure increased stepwise, clearly, right? Over here. It was over here, now it's over here. And then you see what's the change on the flow? No change. This is, by the way, this is internal carotid artery. This is the flow goes to the brain, there's no change. Okay, you don't, oh yeah, I increase the blood pressure, there's no change on the flow. So just remember, this graphical presentation of the results. Here is the table they presented. I want to just emphasize what we just discussed. So it's an internal carotid artery blood flow, and then the red frame is the change in blood pressure. Look here, from 100 to 116, that's a mean, MAP. And then look, what's the flow change is from 198 to 186. Actually, it's slightly decreased. Although statistically, you don't see a difference, but overall, it gives you impression the mean slightly even decreased, but you can regard it as there's no change. Why? The big thing is why? Because we saw, we use the Ohm's law to guide us how to, appreciate, hey, why we manage blood pressure, right? Why you worry about hypotension, why you worry about hypertension, what's the effects on the flow. So if you think of the, Ohm's law, you think of the resistance is unchanged, then you would see a passive flow, right? That's what Dr. Billy's 1895 paper tried to say. However, over here, non-epi in a real human, you give non-epi, you increase CPP. CBF, no change. The CVR, this is cerebral vascular resistance, must have increased and proportionally increased so that the ratio over here remains relatively constant. How? Is that real? Is that true? And how? How is the CVR increased? So this is a different study published in 1928. We are talking about history today. So what they did is in cats, they opened the bone. They use a microscope. They look at the pile artery on top of the surface of the cortex. Okay, this is artery, this is vein. What they did is they gave this time is an epinephrine injection, epi. Okay, following the epi injection, see what happened. So this is before injection over here on the left. On the right is after injection. So the artery is much smaller. There's no change on the vein. The vein is the same, right? This is actually this is machine learning. Nowadays we don't pay attention to what we have done because historically. This is machine learning. Machine learning is all about the visualization, make things, complicated things easier. So this is it. Okay, I'm just kidding. So, but this is why. You would say, oh, hey, you give an epinephrine injection, strong vasoconstriction agent that causes vasoconstriction, right? Really? Really? So here, go back to Greenfield's results. So remember I introduced that. So he monitored both the flow to external, to the tissue bed, perfused by external carotid, and also internal carotid. Okay, on the right over here is the change of the external carotid tissue bed. Okay, so over here, there's an arrow over here. So this is when he gives the injection of a non-epi, just 1 microgram. Where did he injected it? He injected into the carotid artery directly. So what's the change on the blood pressure? No change because this is by second. So you give in the internal carotid artery, if you change the blood pressure is systemic. The whole body is blood pressure, right? So it takes time to go through the circulation and then, and then constrict the systemic arterial system, correct? Right before that occur, see what happened on the flow. Just about about 10 seconds following injection, the flow in the external carotid artery decreased. You would say, oh yeah, that's with the constriction. You might be right. Why? Because if by comparison, you come on the left side, this is the same style. You inject the norepi into carotid artery, and then you measure the flow in the internal carotid territory was a change. Before that increase, the systematic blood pressure increase. Over here, injection, even larger dose, 8 times higher, 8 microgram was a change on the flow. No change, no change. So this give us a striking, impression that if you inject directly into the artery, and then this norepi is, powerful with the constrictor, does not cause direct with the constriction of the internal, but not external carotid artery. Why is that? We all know now it is because of blood-brain barrier. Blood-brain barrier. Okay, by the way, this has to be true. If in the tissue bed, there's no blood-brain barrier, which is the reason why we use norepi to increase the blood pressure, right? If the whole body has a blood-brain barrier, kind of barrier, you would not use norepi because it will not cause direct with a constriction in a patient with a dilation. That's the point. Okay, that's the summarize of what the previous slides. So internal, external, MAP, no change. When you give the norepi directed intra-arterial injection, there's no change. And but flow in the internal, there's no change, but the external, huge change. Huge change. That's why. All right, so what's next? We already talked about that. Okay, so the reason of change because of the blood-brain barrier, you do not cause a direct vasoconstriction. But here's the same person, Sir Billis, came back, 7 years later, published another paper, the same journal, but 7 years later, in 1902. This is what he said. The muscular coat of the arterioles reacts like smooth muscle in other situations to a stretching force by contraction. He's talking about artery, okay? He's talking about the brain, limb, and any kind of artery. And then it reacts to a diminution of tension by relaxation. Basically, of pressure force, it dilates. It dilates. And when the pressure increase, it contracts. Okay, and he said these reactions are independent of the central nervous system. And this is the keywords, are of myogenic nature. So he said this is a inherent property of the muscular coat of the artery. By the way, his experiment, I'm not going to show you the picture. His experiment was not based on vasoactive drugs such as norepi, epi, phenylephrine. His experiment was based on other means of blood pressure manipulation, such as nerve stimulation, cut off the nerve, that kind of work. So ironically, he himself in 1895 said the brain flow is pressure passive. Now he say, well, hey, come on. He did not correct or see differently the relationship between pressure and flow to the brain. But he said this mechanism, that's really, really fascinating. He said, when the pressure falls, vessel arterial dilates, increase constricts. That's important. That's myogenic. Without giving with an active drug, that still happens. That is the key. That is the reason of cerebral autoregulation. So until it is not until 1959. That was about 65 years ago. Dr. Lesson, from Copenhagen, he came here to the U.S. He published this paper when he was a postdoc in Bethesda. Basically, he grouped, 7 different studies and 11 groups of patients. He plotted as a simple scatter plot. not as complicated as machine learning. And he drew a line that is really striking. Why striking? Because this is what the statement from this famous plot. Cerebral autoregulation maintains a stable CBF despite the BP. It's very stable. Okay, a BP change over here on the X, the flow is on the Y. So when the X BP change, look how stable it is. Just a straight line. The underlying mechanism is myogenic, right? We all know now from Dr. Billy's work. See, cerebral autoregulation based on this plot, we have to say it seems very robust. It's just too powerful, perfect. That kind of words, we have to offer to this journal. Okay, this is a real case. Then what happened? So this is a 50-year-old gentleman. Okay, it's a simple thing. It's just otherwise healthy, 50 years old. He injured his arm. He needed a shoulder. He needed a shoulder procedure for I think his rotator cuff injury, and he was on the beach chair for this surgery. And his MAP. So when anesthesiologist, this is not a craniotomy, by the way. Remember, this is shoulder over here. So the anesthesiologist measured the blood pressure over here, right, on the arm. So the goal of the anesthesiologist is, I'm going to maintain 65. But he's not waking up. He is not waking up. So what's the cause? This is the cause. He had a massive stroke on this side. Massive stroke. So it's not that simple. So they talked to the radiologist. There's no sign, no evidence of atherosclerotic change. There's no sign, no suggestion, clue of thrombi, emboli. There's no atrial fibrillation, no lower extremity, DVT. It's so strange. Well, we maintain the blood pressure 65. Dr. Lessing says, if you maintain, over here, this is the lower limit. See the turning point over here? If you maintain the blood pressure over here, see what's that? It's about a 60. Maintain about a 60 above, no problem. The brain maintain a flow, constantly, perfectly. But what happened to this guy? So, well, it's not a simple, right? It's not simple. I would not completely blame a blood pressure management, but his circle Willis is not complete. There's a huge percentage of a population which do not have a complete circle Willis, but his abnormality, there's no ACOM, anterior communicating, over here, right? There's no ACOM. There's on this side, left side, there's no PCOM. But he's fine. He was 50 years old. He was fine. He was healthy. He never had any problem. He never had any brain problem. But after the procedure, he cannot wake up. He had a stroke. It's a real case. How do we interpret this? So, well, there's a lot of interpretations, lots of inspirations here. Can you blame the circle Willis? Not incomplete? For why? And then how about the CPP on the arm 65? Why? Why is not adequate, right? Is that right? What is the difference in CPP? Okay, what is the lower limit for this patient? What is the lower limit for this patient? These are the questions I think we should ask. What's the importance of a lower limit? This is a lower limit. This is a graphing of the autoregulation. This is a lower limit. What's the problem by, maintaining something around the lower limit? This is the problem. If you're not careful, you get trouble. You are not in a points where you have a large margin of safety. That is the implication. That is the implication. So the lower limit can be troubling for us to determine, because there's a huge variation in any population you will talk about. Okay, this is Dr. Drummond from San Diego. He summarized a small editorial paper, cited hundreds of times. Amazing. Why? Because the point is very clear. The different studies by different authors, they use different methods to induce hypotension. They measure blood, CBF. They found a mean, for the lower limit for this, for example, cost study, the lower limit is about 64. However, this is the mean or this is the median. The range of lower limit in that population based on this method, this measurement is 33 to 80. 33 to 80. It's a distribution. We are dealing with individual patient. We are not dealing with the population. That's the difference. That's why the textbook is so misleading, The range of the distribution of the lower limit really extensive. Textbook only talk about the population means, which is a huge problem. We misled, the field. We mistaught our next generations. Remember, we're doctors. We're not a public health. We are not like a government. We are not like a public health department making policies. We are helping each individual patient. We have to know their individual needs. 65 should be abandoned. That's misleading, can cause trouble. The big data, whatever you use mean, median, you have to see, hey, what's the distribution? That's important. The position of the lower limit along the x-axis, which is the CPD axis, is affected by multiple. I'm going to talk about that. We want to know the position of the lower limit for each individual patient, but it's a challenge. Because whoever really measured CBF before, at the same time, you need to measure pressure, blood pressure, or CPP to make a plot, and then you look for the turning points. That's challenging. Right? Lessons work has a problem. The challenge, the misleading, textbook saying like quoted thousands of times, definitely needed to be revisited, and our approach should be rethought. Okay, so when I redid this, actually, Lessing made some mistake in his grafting. Okay, the number 9, this group of patients never existed in the literature. I don't know why he labeled this one. Okay, number 10, he labeled over here above that. Actually, number 10 is very low. That's the real data, right? You go back to the studies, the group, the data Lessing used for his plot in 1959. I replotted 2023. I cannot find the data. Of course, that was done by hands. Now I'm using computing to compute this. I still admire Dr. Lessing because he started the concept of cerebral autoregulation. And then he led the field for so many years. But we need to advance. And I relook at the data again, and then this is what I found. So I put the data together, see the bubbles, because, by the way, he only used, 7 studies, I found 6 studies, not 7 studies. He used 11 groups, I found like more than 20 groups. When I plotted all this group of data, this is the true data coming from these original studies in the shape of the plot, the shape of the X is MAP, Y is CBF. By the way, if you think the green, the light green area over here is a normotensive area, you see what's the CBF over here. When this study decreased the blood pressure in humans, you see the relatively hypotension. This brown colored, see the perfusion goes down. will further decrease the blood pressure to make the patient neurologically symptomatic. It's amazing. All this, we allow researchers to do that. Nowadays, we cannot, which is why we need to respect the history. Because something they can do in the previously, we cannot do anymore. We cannot do anymore. And then you see that goes down and down. Look here, this portion over here, right? Over here. And then you pull the data together, you see a clear, that's a downslope finding when the blood pressure decreases. When you increase the blood pressure for the brain, it doesn't mean the flow will increase. Instead, it slightly decreases. When in the patient with malignant hypertension, it increases again. Therefore, it gives you this kind of the trending line. Okay, there's a plateau here, but there's no clear turning points. Overall, it seems based on this study, this data, the line is kind of like a sloping almost throughout. Although here there's some sort of flattened somehow comparing with here in terms of the slope. This is individual data on this side, individual data. Because this data had never been plotted before, and this also never been plotted before. Because Lessing only selected 11 bubbles from these more than 20 bubbles in his original plot, which is why we look at the history. That's a typical selective data reporting, typical, which will introduce bias. We now know. This is individual data because amazingly, the old studies, historical studies, they report patient level data, which is individual patient data. So from these bubbles, we'll dissect or use the individual data, which led to the bubble here, and then this is the shape of the. If you forget about the trending line, what you see. You forget about the trending line, what you see. It's all over places, individual patient over here, right? The dots, the circles. They have wide distribution, from severe hypotension to severe hypertension, normal tension, hypertension, hypotension, the CBF from here to here, wide distribution. Individuals so different. Our measurement may be so variable as well, right? Our measurement. But this is all measured by Katie Smith method of CBF measurement, which is regarded as a gold standard. Still good standard nowadays. So this work I dissected into different group of researchers' work because Sean, you do some study, use that method with that team of researcher, and then the other person, did a similar study, but with a different group of researcher and different, probably slightly different method. So your data may be different to his data. So I separate. You see over here, Finity's work shows some sort of plateau, but this plateau is positively sloped. But Moore's work is also there's a plateau, perfect plateau, but not perfect, but almost perfect plateau, but negatively sloped when you go from the left to right. Is that suggesting, okay, the lower limit, of course, is the red dot at a different position, and then the upper limit at different position. So you see, this is the points we should get from this data is that cerebral autoregulation is not unchangeable. It is changed. It is changing. It is varying. Therefore, when we manage blood pressure, we have to really, really careful. Consider your patient if the patient has atherosclerotic disease, risk factor, hypertension, smoking, diabetes for years, hyperlipidemia, previous history of stroke, already dementia, forgettable, age, exercise tolerance, all these we need to really careful, right? Really careful. So when the blood pressure go down, see, this is in relatively normal patient. Look at here. When you go lower blood pressure, it does not necessarily cause a symptom, but it does cause a hypoperfusion. If you go further low, cerebral ischemia symptoms will show. All right, so this is, I just want to stress, pay attention to population data and then your individual patient needs. They are different. See, every line is, for one patient. But if you pull this, open squares, closed triangle, closed circle together, you're gonna get a population impression of this relationship. But if you go by, that's as differently, that's individual patients' relationship between these variables. So pay attention to that. Okay, this is pregnancy. I'm not going to talk too much. And then because in the pregnancy, this is also from, the study included by Lesson's work, you can tell for a huge range of blood pressure, the CBF remains relatively constant. So pregnancy offers a huge privilege to pregnant lady of maintaining CBF for a huge range, much wider range of BP somehow. I don't know the mechanism. Cerebral hypoperfusion, it is real. Like that patient, I did 50-year-old shoulder procedure, stroked. Has a range of severity. I talk about that. We know watershed stroke, right? Watershed, that is believed to be a hypoperfusion, stroke. It is real thing. Do not think, oh, if you don't have atrial fibrillation, you don't have a DVT, you're fine. No. What if you have abnormal circular Willis? What if you have atherosclerotic disease inside of the cranium? That's even higher risk. What if you treat acute stroke thrombectomy? All matters. All makes sense now. The problem we let go is because we do not monitor CBF. You think it's a good anesthesia? It may not. It may not. Because nobody measure what the consequence of what you have done. Measure the effects of your anesthetic management. Nobody measure. If we measure it, very likely some variables was not measured as perfectly. I don't know if cerebral hypoperfusion will cause delirium or subtle cognitive change, because how do you measure CBF? But it's real, right? We all need CBF. But what's your definition of hypoperfusion? Right? Therefore, I cannot give you a cause-effect relationship. But we still move on, manage our patient, do our job as a doctor, and then, hopefully everybody doing well. At least in theory, we should be, very well knowledgeable about these things. Of course, no knowledge, no fear, but that's not what we should do. So how to monitor the brain? This is, early days when in Southern California, I was doing the clinical research. Of course, at that time, looking back, I don't have this device anymore. But looking back, this is Doppler, esophageal Doppler, to monitor stroke volume and the cardiac output. I have the frequency domain NIR NIRS, near infrared spectroscopy, cerebral oximetry. This device is still not available commercially. So what we use is continuous wave cerebral oximetry, such as the Casmed, now Edwards, in vitro, now by Medtronic. All that device continuous wave. This is regarded as a much more robust frequency domain device. This is flu track VGLU. This is maybe the first generation VGLU made by Edwards. So we have anesthesia, research computer register all the data. Okay, we use that device, at UCSF. This is what I did. So when the neurointervention radiologist, this is, by the way, this is a 49-year-old gentleman, had a subarachnoid hemorrhage, and he had a clipping about 15 days ago. Okay, he had a hemorrhage 15 days ago. So about 8 days ago, he had a aneurysm clipping. Now, 8 days later, following clipping, he came to the OR for this clip over here. The clip, you can tell. So on this side, you see the with the spasm, and then the MCA and the ACA area. So what they did is see the wire, and then they did a balloon dilation, and then plastic, and see that okay, that worked. So that see the vessel over here. It is narrow. Now it's open, right? Balloon, dilate, deflate, move forward, dilate, deflate, move forward. What I did is this guy in this patient's forehead, I placed a cerebral oxygen probe. When they do the balloon inflation for dilation, you see the drop of the cerebral oximetry. I monitor on the same side of the balloon side. You see here. And then balloon deflate, the oxygen goes back. Balloon inflate, boom, down. A few times, it's so good. I was stunned when in front of my eyes, I saw this. I never expected this. So this is the radiologist doing a balloon dilution, balloon plastic in the MCA. On the forehead, I use a probe, non-invasively monitoring this. Okay. Oh, they finished the procedure. Look, I enlarged this portion over here. See, this is before treatment. This is after treatment. You see, after the balloon dilation, you see what the change? The oxygenation from here to here increased. If you draw a line here, flat line here, increase clearly, right? So this is a proof of that. This is actually a nurse. It's amazing monitoring, technical advancement. So that's a proof. However, you have to really differentiate. What do you do? What is your intervention? In that case, that's the surgeon or radiologist that was doing a balloon angioplasty. But over here is an anesthesiologist giving a vasopressor treatment to increase the blood pressure. Look at the MAP increased. Epinephrine, ephedrine. What's the change on the cerebral oxygenation over here? Decreased. Ephedrine maintained. Why? Over here, cardiac output maintained. Over here, cardiac output decreased. Why is this? This is another verification experiment. So this girl, a researcher, give epinephrine over here. They give epinephrine, this is give nitroglycerin. Give epinephrine, increase the blood pressure on this side. Over the right side, you see the use the transcranial Doppler, the flow velocity increase. And then the same observation as what we had was, give epinephrine. When the flow velocity increased, the oxygenation decreased. Why is this? It doesn't mean the brain is going through hypoxia. It means that this technology has limitations. The limitation is that when you give epinephrine to treat, that's an intravenous use administration, they're going to cause vasoconstriction in the external carotid artery tissue bed, right? At the very beginning of this talk, I introduced Dr. Greenfield's work that if you give a vasoconstrictor such as no-epi, you're going to decrease the external carotid artery to a big degree. And then when you use the cerebral oximetry probe, you apply on the forehead, the light goes through what? Goes through the skin, the extracranial cranial tissue layer. They're going to have a vasoconstriction. Therefore, you they're gonna confound your finding. That's gonna confound your finding because the light, there's a light, near infrared light, go through, shines on top of the skin, go through the skin, the bone, the dirt, CSF, and then samples some of the brain tissue, and some of the lights comes back. And then you get a number. That number is affected by what? It's contaminated by the blood in the forehead skin. That is the cause of this problem when you use with the pressure to manipulate blood pressure, and you monitor brain oxygenation using a nurse. In contrast, the surgeon, when they did the balloon angioplasty inside of the cranium, inside of the MC, they are not touching the external carotid artery at all. Therefore, no such a contamination, confounding exists. Therefore, you get a different impression. So we have to recognize the limitation of this technology, and then we can move forward and interpret the data appropriately. Otherwise, you would believe, oh, I'm not going to give phenylephrine because I give phenylephrine, the brain oxygenation decrease. No, that's not the issue, because when you give phenylephrine instead, this might slightly increase. This is also the data I personally, did is, I get every bubble is data from the previous studies. I plotted the study. They use phenylephrine to increase the blood pressure by a percentage over here with the change on CBF by, different methods of monitoring, measuring, and including TCD, you see a slight increase, right? Which is the same result as here, slight increase, right? And then the previous study also shows, the cerebral oxygenation, about cerebral autoregulation, when you use the method, whatever, to increase the blood pressure, it probably not that robust, as Dr. Lessing stated, completely flat. It is, there's some slope, especially these studies, individual studies, there's some slope. When you decrease the blood pressure, there's also slope. So a perfect plateau doesn't exist. It really depends on patient, method of measurement, and a method of BP manipulation, and also, of course, the integrity of your patients or subjects' cerebral autoregulation functional status. Okay, if it's impaired, problem. Why? Because this. I also summarize the previous studies using no-epi. When they use no-epi in healthy volunteers, this is a different studies. There's some distribution, but overall, you see there's when the blood pressure is increased by no epinephrine treatment, there's no change on the CBF, which is consistent with Dr. Greenfield's research published in 1968. Okay, in the patient population, neurological patient, neurology patient, hypertension patient, but they don't have a critical brain problem. This is fine. Oh, this is over here. This is fine over here. This is this measurement I corrected using the CO2 change, because CO2 also affects the CBF. Okay, the over here is the patient with a problem, with a critical AO patient with a critical AO or brain condition. Most of them had impaired cerebral autoregulation. You see what happened. This is all plus based on the no-epi treatment. You see what happened. So you see here, when the blood pressure is increased, the CBF increase. When you have impaired cerebral autoregulation, of course, impaired, because you don't have that robust myogenic mechanism when the pressure is increasing, your vessel constricts. You cannot like partially paralyzed scenario or completely paralyzed. Or there's some maybe paradoxical, like even dilate. They're gonna cause a paradoxical overzealous brain perfusion. That's disastrous. So this is what the message is. Of course, I'm gonna go through this very quickly, and you may see cardiac output increase CBF, CO2 increase CBF. You give the CO2 increase, the diameter cross-sectional area increase, right? CO2 is a big factor. When BP and CO2 change simultaneously, with the combined effects on CBF. I'm not going to talk about this, but you can tell this is we're going to leave a few minutes for discussion. You can tell this is it matters. All right, this matters. The brain is complicated. Today I want to talk about CBF regulation, but no way. But there are so many factors affect CBF. We focusing on the blood pressure aspect, which we call the cerebral autoregulation. What's the history? Where we should the message we should take from all this data and this our own interpretation. Of course, different organ, not only the brain, the other organ also have autoregulation. This is the heart. This is the muscle, skeletal muscle. This is the intestine. Or myocardium has a strong autoregulatory capacity, but muscle has some, but moderate. But the guts really poor. When your blood pressure change, you're feeling sick in your stomach. That is because your mucosa may be edematous. You don't have appetite, and when the blood pressure is high, when the blood pressure is low, your mucosa is going through ischemia. You don't have appetite. It matters. So maintain a good blood pressure to maintain a good appetite. So I'm going to summarize here. So cerebral is a result of evolution, CA. The concept is maintain a relatively stable CBF despite BP change. But the message from this talk is it does not have a fixed shape. Dr. Lessing's plot was 65 years ago. There's a considerable between subject and within subject variations. We have to abandon the dogmatic parochial view of the shape, the relationship between CPP and the CBF. Do not assume if you never measure. Stay away from the lower limit because you don't have a big enough margin for safety. You may find, but very often you may not find, very often because you don't measure. If you have an extreme case with a patient having stroke, and then we stop. The plateau can be sloped, of course, a different slope, different shape. With the pressure increase CBF. But that doesn't mean there's no autoregulation. Autoregulation exists, myogenic mechanism. In critically ill patient, cerebral autoregulation can be impaired. So therefore, you need to maintain a tightly controlled blood pressure. Tightly controlled. You don't think, you do not assume the patient survived, the patient is fine. Tissue oxygenation has limitations. We have to recognize, otherwise we get misled. Do not forget the other organs. So we do neuro, we do, we do not forget the heart, do not forget the gut, forget about the guts, skeletal muscle, kidney, lungs, right? For the other specialties, cardiac, do not forget the brain, do not forget the guts, do not forget everything, right? You measure the blood pressure for a surgeon. Oh, let's do a deliberate hypotension. What's your concern? How do you convince the surgeon that may be too much? So lots of questions. I appreciate the privilege of talking right in front of the July 4th. Thank you. That's it.
LZ, that was an excellent talk. Thank you. I just had a quick question to ask you from kind of a practical standpoint. You talked about some of the inherent problems with drawing meaningful conclusions with population data with respect to some variables like cerebral blood flow, because they can underestimate the lower threshold for some of the patients with respect to cerebral ischemia. So chronic hypertension, obviously something that, was pointed out, something that's been well documented for many years. It clearly has an effect on autoregulation with respect to shifting the autoregulation curve to the right. But then you also highlighted that there's a number of other factors, and some of them might be a little more subtle, some anatomical factors. You mentioned other things, atherosclerotic disease, history of dementia and other things like that, that also might play an important role. And they also might be much more difficult to measure for most of us in the operating with the standard monitors that we typically measure. So from a practical standpoint, you pointed out that a lower threshold of 65 millimeters of mercury is probably too low, at least for some patients. The example that you gave with the patient undergoing the shoulder surgery, obviously that's a more extreme example. But a 50-year-old patient and the end result is a stroke is clearly, something that's pretty alarming. And then another thing I thought was pretty alarming is, one of the graphs you pointed out showed that even systemic pressures as high as 80 millimeters of mercury still could be in the hypoperfusion range. Again, at least for some patients. So again, this is kind of alarming. I was just curious from a practical standpoint in your own management, obviously your neuroanesthesiologists take care of these patients in the operating room. With respect to that lower limit, what is your general approach for managing that lower limit or for estimating that lower limit? Is this something do you take a approach where most patients, do you try to keep them a little bit higher as far as the lower limit, maybe closer to 80, maybe some other number, or is this something that you will change depending on the patient, depending on the patient's characteristics, at least the ones that you can observe and measure?
Yeah, Sean, just as you pointed out that when I approach this, I always ask a patient, hey, what's your blood pressure? Are you taking pills? And then when you see a doctor, what's the number? Do you remember the number? Some patients just don't care, don't remember anything, but you just take a good guess, look at the body habitus, the income, I look at the teeth. If you have a poor teeth, dental condition, and you don't care about yourself. So if you're relatively, consider everything, smoking and all these things. I have, a guess. I regard 65 is too low for you. I would tell my resident, every time I measure the case in the room, I will, tell my resident clearly that, hey, 75 is a go. Okay, if for poorly controlled hypertensive patient, 200 over 110, obviously, hey, let's maintain 95. Sometimes I do that. Let's maintain 95, 100. If the surgeon concerns, let me know. I will come in and interpret, the situation. And then if the patient like 165 over 85, that kind of range, I see, well, yeah, no lower than 80 probably. If 140 over 80, I would say, yeah, okay. At least 75, it's kind of like a 10-20% of range of, I typically tolerate, but sometimes a certain hour is too high, I will reassess the situation. So it's not, as you said, it's not easy because most of the time we don't monitor the brain flow, and then we don't know where the lower limit is. We don't know the shape of the plateau, how wide is the plateau, what is the slope of the plateau, where's the lower limit, and then even what's the upper limit. So what's the best blood pressure for the brain, and at the same time, I'm not ignoring the gas, the myocardium, kidney. So yes, and also there's a big component that you do not want to only focus on the pressure. What is the flow? The flow matters. Why we monitor? Why we care about the pressure? Because we care about the flow. If you give a lot of vasoconstrictors, you have a good pressure. Doesn't mean you have a good flow. We already know the previous experiment from phenylephrine, no epi, right? So the cardiac output instead will decrease. Is that a good thing? A good thing maybe for the brain, right? The brain likes pressure, the kidney likes water. But you don't want to have a neurological patient afterwards, you have a AKI. Creatinine increased, and then the doctor reluctant to discharge the patient home. So yes, Sean, yes, that's how I would approach how I manage blood pressure for my patient.
Dr. Meng, thank you. Dr. Quinones here from Neurosurgery. I see two questions. Dr. Thorpe, are you still on the line? Do you want to go ahead and ask your questions? Oh, where are you? Oh, okay. Here, I pass the microphone. Perfect. Oh, you got it.
All right. Thank you very much. Great talk. I saw you had a lot of graphs about epinephrine versus no epinephrine. Any thoughts on vasopressin and cerebral blood flow? I don't know. I haven't. I don't know. So I thought I'd ask the expert.
Yeah, vasopressin, not many studies on vasopressin. The previous studies are primarily dealing with non-epi, phenylephrine, and epinephrine, and dopamine. Unfortunately, I don't know. I don't think there's much results related to vasopressin. And nowadays, very few people study, this kind of physiological effects, following with an active drug. So yeah, but vasopressin, we cannot assume, how vasopressin affect cardiac output, how it affects the, I don't think vasopressin cross the BBB, and vasopressin should follow the same, in theory, follow the same pattern as the non-epi as far as CBF is concerned.
One last question, Dr. Meng, if you don't mind. This is Dr. Q again here for neurosurgery. In regards to the, I'm fascinated by this concept of cerebral flow regulation. And that's one of the reasons why over the years I have transitioned to keeping a lot of my patients awake. I don't think there's a way to better regulate your own autoperfusion, your own body. I mean, the body has created a masterful way of doing so. And I was just commenting here with Carlos, who's to my right. The camera probably will pivot into him. And there you go. So about the fact that we can easily look at the subtle changes that may happen with patients that we do craniotomies, in which we keep them asleep, and the controlado side of the brain as compared to those that we keep, awake. And probably we're going to find subtle changes that are already occurring that we don't pick up, because the reality is the case study that you show, we don't look at those anatomical variables in a lot of our patients, and we're probably missing a lot of very subtle changes that are happening. So your thoughts as far as what happens when patients are not, I mean, I don't know if our team told you they have this anesthesia, the neuroanesthesia team has these amazing protocols where before the patients go into the operating room with the ultrasound, they block all the nerves, and they're very, very comfortable, they're wide awake, and we're doing all these amazing procedures. Any thoughts about what happens when those patients are awake in regards to the auto-regulation of the blood flow?
Well, the awake is probably the best condition we can offer our patient for the maintenance of CBF autoregulation. So we know the general anesthetic, the inhalational, such as the sevoflurane, inhalational gas has an intrinsic vasodilatory property, and that impairs cerebral autoregulation. So therefore, intraoperatively, when you have a change in blood pressure, no matter which direction, you are more likely to have a change in CBF. And for propofol intravenous, we know it does not have intrinsic cerebral vasodilatory property. So propofol is regarded as the drug that maintains cerebral autoregulation much better, much better, or even maintains it. So than inhalational. So regardless, I mean, when the patients are awake, we are, offering the patient the best opportunity to maintain his own, regulate his own hemodynamics in general, and CBF in particular.
Thank you, Dr. Meng. Well, thank you. As you can see, we had over 70 participants at one point from 10 different countries, what I saw from our team, and then about over 40 participants here live having breakfast this morning, listening to your amazing lecture. I don't know if Dr. Abel is on the line or not, but we thank you immensely on behalf of anesthesia, neuroanesthesia, Dr. Gruenbaum, our Department of Neurosurgery. We have a lot of our consultants here. We're fascinated by this topic. We want to learn more. We want to do more. We want to create intraoperative studies in which we can obviously not only learn, but also eventually modulate and regulate so we can actually benefit our patients for better outcomes, not only for brain, but also for spine. So we thank you immensely for your time, your dedication, your extraordinary talk. We love your energy. As Dr. Gruenbaum said, there's a reason why you do so many invited lectures, and hopefully we'll have you in the future and in not too distant future here in person with us. So thank you.
Thank you. Thank you, Dr. Kiel. Thank you, everybody.
Thanks. Have a great day.
Bye-bye. Have a great day.
Thank you.
July 1st. Yeah, bye-bye.
We'll send you a plaque. They should have a plaque for you, actually, that our team will send you. Thank you.
All right. Yeah. Thank you, Dr. Q. So, all right. Bye-bye.